All right, good morning, everyone. I think we're gonna go ahead and get started. We are on to week 9 of our Tackling Type 2 Diabetes series. I'm Jessie Lewis, the clinic coordinator. I'll go through the usual reminders and then turn it over. So please be sure to chat your name and your practice name into the chat feature for attendance. Remember that you can rename yourself in the participant list if your full name isn't showing, so you can hover over your name, select more, and then select rename and type whatever text into the open field there. Please be sure to keep yourselves on mute unless speaking. And then of course you can comment or ask questions using the chat feature at any time. So with that, I'll go ahead and hand it over to Dr. Duncan.
Well, good morning, everyone. I'm Kathleen Duncan, endocrinologist at OSU, and I'll be facilitating today. Dr. Rao, are you on? Would you like to give yourself an introduction?
Sure. Thank you, Kathleen. I'm Goutham Rao. I'm the director of the ECHO program, and I'm at Case Western, where I serve as the chair of family medicine and community health.
And Dr. Rao will also be one of our didactic presenters this morning. In addition, Adam Przezinski will be presenting. Go ahead and introduce yourself.
Sure. Hi, everyone. My name is Adam Przezinski. I'm a sociologist at Metro Health in the Population Health Research Institute, where I conduct research on how social factors influence cardiovascular outcomes.
Great. And then finally, our case presenter today is Dr. Stephen Swedland from Wright State. Are you on? Oh, there you are. Hi.
Yes, thank you. I'm at Wright State University Geriatrics, and I'm a program director for the Geriatric Fellowship. Thank you.
Well, great to have you with us. Okay, so this is the structure of our clinic as usual. We'll have a brief our introduction followed by a didactic presentation, and we want to save some time for question and answer. And at that time, you can turn on your video cameras. Feel free to chime in as much as you can, and or use the chat feature. That'll be followed by our case study, which will be about another 25 or so minutes with a discussion toward the end of that. All right, with that, we'll proceed to the next slide, which is our disclosures, and those were sent to you earlier in the week. Next. And without further ado, let's go forward with our didactic today, which is the food sources and type 2 diabetes. Dr. Rao, take it away.
Okay, thank you, Kathleen. Thanks, everyone, for joining us this morning. So I'm going to start off, and Dr. Przezinski is going to take over about halfway through the didactic portion today. Let me start by saying I think everybody kind of comes to the same place. If you're passionate about preventing cardiovascular disease, which I am, you then have to be passionate, of course, about preventing cardiovascular risk factors, which of course includes type 2 diabetes, hypertension, etc. And then you ask yourself, well, in whom would I try to prevent these cardiovascular risk factors from forming? And everybody kind of gets to the point of young people and children, which is how I got interested in this whole area of food sources, which we'll get to in a moment. So certainly everything that I have to say applies, of course, to adults, but it's kind of stepping backwards a little bit and telling you why I think we all ought to be advocates for healthier food sources in our communities. So the objectives are: describe how available food sources influence risk and control of type 2 diabetes, how taste preferences influence body weight, and the impact of public health efforts to improve the healthfulness of the food supply. Next slide, please. So this is well-known information. There's nothing new here. And I think that if we keep, if we just mention this disparity as a serious problem without looking at the underlying causes, we're not really doing justice to the issue. So the overall adult obesity prevalence, this is relatively recent, is 42.4%. Non-Hispanic Black adults have a higher rate of obesity. Latinx folks have slightly higher. Native Americans have very high. These are a little bit misleading because within these groups, there are subgroups, obviously, that have even higher rates of obesity. Non-Hispanic Black women in particular are much higher than this. Next slide. So this is a confusing slide, and people say, well, why do we have these disparities? And there's not a simple answer to it. So I think that's the first lesson from this didactic portion. Does nutrition affect disparities in obesity, and what influences nutrition? So let's talk about some of these slides. So in general, it's perceived, and with good reason, that nuts and seeds are healthful items. The more of those you eat, you're generally have a lower body weight, lower cardiovascular risk. And as you can see from the top panel, depending on your level of education, you are more likely to eat more servings of nuts and seeds per day if you are better educated. The second panel is fruits and vegetables, and this deals with income, which of course is highly correlated with education. And you'll see that the more educated you are, the more likely you are to have more fruits and vegetables. The disturbing thing for me is that in the highest education and income levels, the disparity grows over time. So in other words, the healthy are getting healthier in some ways, and they're outpacing people of lower income and lower levels of education. Sugar sweetened beverages, of course, considered to be an unhealthy item. And as you can see, this is an particular age chart. Senior citizens actually consume the lowest amount, and you can see that there are higher amounts in young people, which does not bode well for the future as well. Next slide. So this is another slide looking at healthful behaviors, but this is organized by race and ethnicity. And there was some encouraging news here. So whole fruit, of course, which includes fiber, is generally considered to be healthier than fruit juice, which is consumed in very large quantities in some communities. And you'll see that the amount of whole fruit has increased over the last 20, well, these are older slides, for about 20 years or so. And the amount of fruit juice has dropped across ethnicities, which is encouraging. Next slide. So this is the most important principle I want to leave with you today, because there's a lot of confusing information out there. Consistently across all surveys, the number one decider in terms of what people choose to eat is whether they like the taste of it, okay? That's what counts. The famous experiment from the 1980s where they had a food bank, and I've mentioned this many times. Food bank usually receives $1 per loaf white bread from a bakery. And for a few months, this is in Burlington, Vermont, not a diverse community by any means. But for a few months, they received artisan whole wheat bread with nuts and seeds that cost $5 or $6 a loaf. They put them side by side in the food bank. There's no difference in convenience. They're both free. And the food bank customers, of course, who are of low income, almost always chose the $1 per loaf white bread. Why? Well, it's because of the taste. So that is the number one driver by far. This is a commercial survey. Number two is price. Healthfulness and convenience are about the same. The least, it's only the people perhaps on this echo who are terribly worried about sustainability, farm to table, locally grown, whether something is organic, et cetera, et cetera. That's a very small slice of the population. And for most of our patients who suffer from cardiovascular risks, including type 2 diabetes, it's a very low priority. Okay, so keep that in mind as we go through it. And we'll talk a little bit about taste and how we can influence taste, and how sometimes I think we're investing in the wrong place. Next slide. There's so much information about this that I think it's one of those settled questions. If you give the poor easy access to healthy food, it doesn't mean they'll buy it, or it doesn't mean they'll eat it. So there's a lot of pushes, of course, to build supermarkets in poor neighborhoods. And I support that because I think it has a number of benefits, employment being an important one. But it doesn't mean that it's going to help you fix problems with healthy eating or prevent type 2 diabetes or cardiovascular problems. There's never been any evidence of that whatsoever. This is in the Bronx, where I used to work at the University of Chicago. There was a big fanfare about building a Whole Foods on the south side of Chicago. And as I've joked many times, the only people I've ever seen in there are faculty members from the University of Chicago shopping on their way home to their wealthy suburbs. That's not exactly what the intent was there. It's too expensive. The kinds of things don't appeal to the people who live in that poor community. So this is one sign of it. The idea of food deserts has certainly been cast in doubt many times. And the reason is where you live and where you shop for food are not the same things. It isn't for me. I live out here in Chagrin Falls. There's not a whole lot out here. And this is about 20 miles east of Cleveland. So we tend to shop, closer to the city. And that's normal for many, many people. So that's one aspect of it. And in big cities like Philadelphia or Chicago and to a lesser extent Cleveland, you can pretty much get what you want within about 1 mile of your home if you really want to. So, so food deserts have been cast in doubt as a concept that explains some of the disparities that we see. Next slide. This is, I think, the nicest, the most apt phrase to describe the phenomena. We built it and they did not come, using governance theory in the fight for food justice. So let's unpack that a little bit. We built it refers to building healthier food sources, farmers markets, supermarkets, helping small bodegas or convenience store stock fresh produce. You can build the infrastructure for healthier eating, but it certainly does not mean that people will take advantage of it. So governance theory refers to governance, which keeps in mind principles of equity and social justice. And food justice is another concept that we will discuss in a moment. So food justice can be defined in many ways, and we'll talk about the traditional definition in a second. But it's not the opportunity, right, just to purchase healthy food items. It's the motivation and encouragement to do so, which is quite a different sort of thing. You can put a supermarket in a poor community, but if people who shop there, who have type 2 diabetes, who are in their 60s, have eaten a certain way their whole lives and are accustomed to a certain taste, a certain convenience, certain type of packaging, it's not going to make any difference. Next slide. So there's only two ways around this problem that I can think of. And one is public policy. If you want to watch this, you're not going to watch the whole thing. This is a congressional hearing where I spoke in 2014. The issue there was school lunches. So school lunches fall into two categories. There's the USDA approved lunch, which has to meet certain nutrition standards and typically is not as flavorful, I think, to most children, as what are called competitive foods. These are foods that are sold alongside the standard lunch. And schools sell competitive foods for many reasons, probably because they make some money out of it and it supports their school system. And I've always argued if your school system is relying on selling chips and candy to support itself, there's something wrong in the way that it's financed. But this is one way to do it. And back in 2014, in the Obama years, the First Lady wanted to, and her husband obviously wanted to regulate the nutrition standards for competitive foods, which is something I supported. It didn't go anywhere, unfortunately. There's some very, very powerful vested interests against this idea. But it gives you an idea that public policy may be able to influence what we eat. The other example I've been involved in is taxing sugar-sweetened beverages, which has had some limited success in some parts of the country, such as Philadelphia, and there's been some statewide efforts as well. Berkeley, California was the first place to do that. I think that has a small effect. It's more of a symbol. It's more of a symbolic effect more than anything else. But it tells you that this is a very, very tough road to go through. And I think it's because we don't talk to individual patients and families directly who are coping with some of these issues. Next slide. So what's the other approach? So we talked about public policy. Public policy can have a significant impact. So we know, for example, that regulating food and Head Start programs in big cities and on the East Coast has had an impact on childhood obesity, for example. We know that not all developed countries have the same rates of obesity, and it's not always related to culture. So rates of obesity are much lower in some countries in Europe, which are also very wealthy and have pretty much the same infrastructure with respect to food. But here's the idea of food justice. So the traditional food justice definition, this is from people in the economics and health policy fields, is communities exercising their right to grow, sell, and eat healthy food. Now, I don't know of anyone who would object to that. So you have all of these urban farming, you have farmers markets, et cetera. That's all fine. Healthy food is fresh, nutritious, affordable, culturally appropriate, and grown locally with care for the well-being of the land workers, and animals. Now, that's a very aspirational sort of type of food justice. But to the average person among our patients who are struggling with illness, who comes into your office and says, you know, I can't seem to get my type 2 diabetes under control for lots of reasons. And I believe it's how I eat. This isn't a terribly helpful sort of thing. And when you ask them, well, where do you buy your food? And they say, I go to Dollar Tree or Dollar General, or I go to the local convenience store, and this is what I'm accustomed to. Or more often than not, I purchase my food through fast food outlets and other takeout type facilities. So this sort of traditional food justice doesn't really help you. And you can say, and of course, people often revert to a more political stance and say, well, if only there was a fresh fruit farmer's market in my community, that would be wonderful. It may not make a lot of difference. So I have proposed redefining this as the following. Food justice involves refusing to purchase and consume unhealthy foods, which have for generations been marketed and sold aggressively in poor communities and communities of color. So this is a motivational type of statement. There is no question, if you look at advertising to children in particular, but also to young people across the country, that minority groups receive targeted advertising for foods that are high in sugar, fat, and salt over and over again. And it's very difficult if you've been eating that sort of stuff since you were 3 years old to change your taste preferences. So we have to start with, is this justice? Let's not worry about sustainability of the land, et cetera. Those of us who are able to worry about those things can do so. But I think the average person has to ask them. I remember asking this question in inner city Pittsburgh, that the people in this one community had lobbied so successfully for better public housing, for better public transportation, for better policing, more just policing. And yet there was the only restaurants within a 1 mile radius were McDonald's and Burger King. And I said, well, why are you allowing this? This is something that influences everybody's health. And look at the lineups and look at how busy they are. Look how much money is being made in these institutions that have marketed themselves so successfully to you for a very long time. I think that's another way of doing it. The other approach we've tried, and this is based on, it's not my idea, he was a graduate student I worked with many years ago. He was originally from Oakland, California. He was African-American. He was an older student. He was in his 40s and was starting graduate school just because he was just so passionate about things. And none of the foods that are commonly consumed in minority communities or in rural communities, the packaged foods, fast foods, et cetera, have any traditional basis. Okay, the Big Mac has no cultural tradition behind it, basically. It's marketed it's really just designed to increase consumption. Yet there are traditional foods that exist in these communities that have been ignored for generations. And as has been written before, if your great grandmother doesn't recognize what you're eating, you shouldn't be eating it at all. So I think motivating people from this standpoint, empowering them to make choices based on what they see, rather than asking for something new that may or may not make a difference, I believe, is another approach that we can consider. Whether it works or not is a separate question. So I want to leave you with a couple of messages. One is the importance of taste above all. And this does not apply just to poor people or communities of color or people in rural areas. It applies to all of us, okay? We might like to think that we will eat something that's healthy if we don't like the taste, but we won't eat very much of it. And this has been shown many, many times. That's, I think, another thing is, and I think the other thing is that some of our approaches have to be rethought. So there's no question that providing healthy food to communities has some effects. It tells people what healthy food really is, provides employment, et cetera. But I really think it's staying away from unhealthy foods that is the approach that will have the most impact overall. So thanks very much. And I think we'll turn things over to Adam.
Great, thanks, Goutham. So I'm going to talk to you about food environments, and we're going to go upstream a little bit. I like this particular figure from National Health Service Scotland that sort of breaks down social factors in health in general. But I think food environments fit nicely in here. And the point that I like to make about this is that most of the things that we do for most social determinants of health, food insecurity and nutritional quality included in that, are relatively downstream, and they focus on individuals and they're sort of like mitigation strategies, and they don't really sort of go to the left side of this diagram where we see more fundamental causes. And so I think thematically, I'm just going to sort of walk through some pieces of that for you today. Next slide, please. So, and another way to say this is that some of you are familiar with these screen and refer models that are growing at an unbelievable pace in clinical settings, where you ask someone, for example, are you having trouble buying food? Have you run out of food in the past week? And then maybe there's some brief intervention and some referral to food pantry, food pharmacy, food bank. And while these approaches have sometimes been shown to have tremendous benefit, they don't address the underlying characteristics of communities that place people in a position where they're limited in terms of the foods that they might consume. Next slide, please. So this is a measure that I'm going to throw up here because it characterizes some of my own work, and it describes nicely some of the patterns that go on in our communities in Ohio. It's called the Area Deprivation Index. It consists in this iteration of these 15 indicators, which are grouped roughly, sort of at the top into sort of money type indicators, the value of homes, the cost of living somewhere, the percentage of families in poverty, but also the structure of households, whether people have vehicles. So it's sort of a broad index of socioeconomic disadvantage. Next slide, please. So if we use that to characterize Ohio, what we see is, for some folks, a fairly familiar picture of our state, which is that we have this wide swath across the southeast edge of the state where most communities are at higher levels of disadvantage. And then we also see that folks who live in the center of our cities, whether those cities are small or large, tend to be the most socioeconomically disadvantaged, with some strange exceptions like we see in the call out. The call out there, the little triangle in the middle, is actually University Circle, where Case Western is. So that gets a sort of blue oasis of low disadvantage and sort of a sea of disadvantage in the center of Cleveland there. Next slide, please. So we conducted this analysis a few years ago using electronic health record data and that same socioeconomic neighborhood disadvantage data to understand how those factors influence people's cardiovascular risk. Next slide, please. And so in this study, we compared about 140,000 individuals in Northeast Ohio, followed over 5 years. And we looked at what their estimated risk of having a hard cardiovascular event was, using both the American College of Cardiology pooled cohort equation and the socioeconomic characteristics of their neighborhood. So this is just a sort of drawn out view of what is Northeast Ohio. So roughly 11 counties in Northeast Ohio. So it's very similar to the area deprivation view you saw for the whole state. Next slide, please. And the troubling thing that we see is that the hazard ratio for having a cardiovascular event is almost identical to the patterning of neighborhood disadvantage across our communities in Northeast Ohio. Next slide, please. But even more interesting was that we found that people's neighborhood socioeconomic position alone accounted for 32% of the variation in whether they had a cardiovascular event in the 5-year follow-up period. And just 10% was explained by the clinical risk factors in the pooled cohort equation. So these are smoking, blood pressure, lipids, diabetes, age, sex, the things that we typically associate with cardiovascular outcomes. And those were sort of drastically trumped by people's neighborhood socioeconomic position. Next slide, please. This is, so the sum of this is that people in high disadvantaged communities don't live as long. And so here you can see in the left panel, we've highlighted the most advantaged and the most disadvantaged two neighborhoods in Northeast Ohio. They happen to correspond to the neighborhoods of Huff and Lyndhurst. And so we've highlighted them by both life expectancy and by neighborhood socioeconomic disadvantage. And what you can see is a rough correspondence there and a difference of, sort of roughly 20 to 30 years of life expectancy. Next slide, please. So I'm going to propose to you that community structures are critically important for health and food choice, and that your neighborhood really can influence your cardiovascular disease outcomes, whether you get diabetes in the first place, how well you manage it, and some of the characteristics of food retail environments that Goutham was mentioning. Next slide, please. So one of those characteristics, as opposed to just thinking about the presence of healthy stores, there are some measures called the Retail Food and Environment Index, the Modified Food Retail Environment Index. This one's the RFEI. And it's basically a simple ratio where the numerator consists of stores that sell a lot of foods that are disproportionately bad for you, and the denominator consists of stores that sell a lot of foods that are disproportionately better for you. So I think the note in this slide says that in California, the average is about 4.5. So that for every grocery store, there's 4 fast food restaurants or convenience stores in a neighborhood. That's for the state of California. I don't know what the average is for Ohio, actually. Next slide, please. But the legend here is really interesting. My favorite thing is about that equation is that you can't, right? We all know from our basic elementary school arithmetic classes that you can't divide by 0. So, so we just set the value to 0 when the denominator is 0 because we don't know what the value would be. And in here, all of the red, all of the red census tracts in Ohio actually have 0 healthy foods. So these are what Goutham was talking about as food deserts. The other thing about this is like there's a high concentration of these in the rural counties. And just as Goutham was saying, is that in urban and suburban areas, everybody lives pretty close to a whole bunch of different types of food choices, right? Like there's just like places are sort of inundated with places to buy food when you live in most of the urban areas of the state, with some exceptions where there are a handful of neighborhoods that really have no healthy food options. But this really does, this image does sort of tell a somewhat different story of food choice in Ohio. Next slide, please. The other thing that we know is that from multiple studies, we know that retail food environments are associated with the incidence and prevalence of diabetes among both adults and children. So these community structures have associations, but I think it really is important to remember the component of Goutham's talk where he reminded us that just putting the stores there isn't going to correct this, right? So like while this sort of structural disadvantage exists, just because we solve for the food environment, that alone may not be enough to restructure the profile of cardiometabolic disorders in our communities. Next slide, please. So I love, I do a lot of my work is also more qualitative, and I love this one particular paper from South Africa where they interviewed folks who most of whom had diabetes about the trouble that they have getting food and the things that are good about getting their food. And they used a tool called Photo Voice where they had people just take a picture of their community that gave an impression of what challenges and opportunities they had with regard to eating healthy as a person with diabetes. And one of those was distance. And so this is just a great photo of like, well, if somebody has no transportation and this is sort of where they live and they have to go pretty far, like as far as the eye can see, to get healthy food, they're not going to get healthy food, right? So like you can have these sort of imperative barriers where like there's an imperative to healthy food that you can't transcend if you don't have transportation. Next slide, please. On the other hand, I love this quote. I prefer to have a fruit and veg street vendor that makes it easy for me to buy vegetables in the street. It makes it easy for me to cook because I don't have to go down to get vegetables. It is also good for people like me to have veggies for my health as I am diabetic. One of my first experiences when I moved to Cleveland in 1999, I lived in a fairly urban neighborhood. A very mixed income neighborhood, very crowded neighborhood. There actually were not a lot of healthy food choices around. And there was this guy who had a big Lincoln Town Car. He used to pull up on my street every Thursday and pop open his trunk. These folks are often known as hucksters. And he had a trunk full of fresh fruit and vegetables. And it was awesome. I could just walk down my front step and take $5 or $10 and buy some grapes and some carrots or whatever I wanted out of this guy's trunk. It's sort of a local pursuit of food justice. It was great for him to make a little money. It was great for me. I didn't have to travel as far to go get food. It was also sort of like a hangout where people in our little urban neighborhood, like I might actually see my neighbors. So I think that the strategies for addressing these challenges are varied and diverse across communities, and we probably don't always think about all of the possibilities for designing healthier communities. Next slide, please. I want to highlight this sort of review article on food environments. So we know that people who live in poor food environments consume more sweetened beverages. We know that they consume more fast food, and that we know that these neighborhood influences alone do account for millions of additional unhealthy meals per week in every state. Next slide, please. We also know that things are different within states. So this is work by Darcy Friedman at Case Western, where they compared the differences in perceived control over eating, food choice available, support you had in your home, how often you shop for food, how far you have to go for food, and how all of those things influenced healthy eating. And what we found was this hypothesis model, or what Darcy's team found in this hypothesized model, was that so a couple of things you can look at here. The explained variance in healthy eating in this model in Cleveland was about 15%, 0.152. And income was a pretty big driving factor, but not necessarily the deciding factor in the model. Next slide, please. But if we look at Columbus, almost twice, the same model explained almost twice the variance in healthy food, explaining almost 30% of the variance. And income was a much bigger factor in food choice in Columbus. So this is really fascinating analysis. But I think it also gets at some of what Goutham was saying, which is that we can't necessarily assume that just putting a grocery store somewhere is going to solve the situation in every community, because our communities are texturally quite different from one another. Even two large cities in the same state can have nuance and differences in food environments and food choice patterns. Next slide, please. So and I'm going to try and end on a more positive note. So we know that improvement is possible. We know that efforts to improve healthy food availability and reduce costs are associated with small improvements in diabetes outcomes. We know that partnerships between clinics and community members are usually met with a really positive community response. Most of the time they show improvement, and it's the kind of thing that feels good in a clinic. And then we also know that though that our understandings of food environments are often based upon like anchor institutions or individual level food decisions, but we've not done a great job of thinking through the activities that people engage in, like where in your day do you consume food, and sort of charting from when you get up to when you go to sleep, what your food environment is, as opposed to just your address of residence, because people eat where they work. People may never eat or shop within a mile of their home. So I think really thinking about, again, designing equitable, healthy communities and food environments. Next slide, please. And that's where I'm going to leave you. So I think this framework by Kumanika from National Academy of Medicine is pretty strong. And I would characterize it as a holistic model for designing healthier communities. And so that drive and that sort of equitable holistic model drives healthy behaviors. So that policy, the big policy hammer, tax subsidies, anti-hunger programs, increasing employment, those are good, but alone they're not enough. We also need places where people can live healthy. We need to reduce interpersonal microaggressions, and we also need to promote healthy behaviors. And I think that's it. So we might have a little time to take a few questions. So I'll hand it back.
Well, thank you. That was really, really fascinating, Goutham and Adam. I did see a question come in during the didactics in the chat. I'm not sure who it's from, but if you want to, restate your question, please feel free. Was this question answered? Because it came in early. It was when you have low income areas like East Cleveland, where do you start with trying to get healthy foods into those areas? And if the person that submitted it wants to clarify.
I mean, I think I'll offer a,
I cannot submit that question. This is Pamela. But I disagree with a problem with food deserts not being a problem. I live in a community. I don't live in a community, but I work in a community and serve in a community, the Lee Harvard area. And we bring fresh fruit and vegetables in from farmers markets, etc. And people swarm to get that food. And it is food desert. And I disagree that food desert is not a problem. It still is a problem. Just like pharmacy deserts are going to be a problem with getting the vaccines. So I don't know where that data came from or how they came to those conclusions. Another thing is you have to teach people how to cook certain foods if they're not used to it. There had been an explosion on greens. We like collard greens, and we used to use ham hocks in the collard greens. Now you'll very rarely see anybody using a ham hock. They will use turkey, smoked turkey instead of the ham hocks in their greens. So I'm not sure where the information came from, but I do disagree with that.
So I can address that briefly. I think a lot of people are invested in the concept of food deserts and certainly believe that food deserts exist based on the definitions that have been provided. And they are problematic. There's no question that you are better off if you have healthy food sources within your environment. And there's no question, there was a farmer's market in Evanston, Illinois, which is a very, very, very diverse community. Same response, people are using their social benefit card. They can apply it to get food at the farmer's market, and they are swamped. Of course they're swamped. What I think the research shows is that this is not a effective solution for preventing diabetes, improving obesity. People are very self-selected. It's just like healthcare in general. The people that take advantage of preventive healthcare, generally a little bit healthier, more health conscious than the rest of the folks out there. I know Adam wants to address this question as well. How do you start to get healthy food in underprivileged communities? So you can empower those people in those communities to demand healthy food, or even better still, to avoid unhealthy food, I think is a better strategy. The second thing, and referring to some of the articles that have come up, is to nudge people towards change. That works. So people don't realize it, but the amount of sugar in cornflakes goes down every single year, just a little bit. If it goes down too quickly in any given year, kids won't eat it. Britain has actually done a very good job of this. So their cornflakes, their cereals, their salty foods have less salt and less sugar than we do have on this side of the Atlantic. So that's called nudging people. In other words, moving them slowly towards healthier behavior. And the other third strategy, which we talked about already, is health policy. Now, if you look at sugar-sweetened beverage consumption in communities of colors, Latinx communities and African-American communities, it has gone down significantly, not because of health policy, not because people are making Coke a little less sweet than it was last year, but because of greater awareness, greater empowerment of people who actually live there. People who say, I know these are unhealthy beverages. I hear it all the time. I don't want to support the consumption of unhealthy foods. So I think those are some of the strategies.
We also have to address and take into account those inequities when we're proposing solutions to food environments, because like just bringing a bunch of heads of lettuce into a community, while it might have some benefit, is really not enough in the long run.
Great, thank you all. That was a really great discussion. And if we can pull up the case, I'd like to pivot to our case today to further discussion among the group. Is he currently on any therapy for diabetes? Just real quick.
He's on insulin. He's on basal insulin, 46 units of glargine. And he has a sliding scale. It's something he was getting his care from the VA until about 5 years ago. And he's on the same, I have titrated his basal insulin up some, but he's essentially on the same routine. And so I kept him on the same routine because he seemed to be doing well with it. But I'll take advice if somebody wants to point out a safer thing for him.
So Kathleen, I just had a question for you and perhaps one for Stephen. I want to piggyback on Sherry Boland's question as well. I think it's pretty remarkable that he's 96, read a cookbook and able to cook for himself. I mean, that's pretty amazing. So Sherry was using packaged foods or canned foods. My other question, I think probably for Kathleen, is my understanding is in these very elderly patients, hemoglobin A1C has a tendency to creep up in any case, even under optimal management or optimal treatment per se, and that perhaps our standard for targets are not applicable to someone who's 96 years old. So
yeah, I mean, I would say presumably with some discussion with the patient that your target might even be just making sure that you're not causing undue symptoms or impairing the quality of life, and whether that means an A1C of 8.5 or I would think probably an A1C of 10 would probably induce some adverse sort of issues with quality in life and additional symptoms that maybe could be improved.
Yeah, I think when he's had more glycosuria and getting up at night more often lately. So I pointed that out to him, that if he could work on his diet, we could possibly help that out.
And Karen, did you want to offer suggestions? I think I see something in the chat from you.
Yeah, and I don't remember what insulins he was on, but sometimes with people, just a conversation, a little bit more of a lengthy conversation about when meals are, what they're eating, who's making the meals, how are they getting their meals, and the timing of insulin can really help bring, maybe bring the A1C down a little bit. I don't remember if he was on mealtime insulin or not, but that's my experience. Sometimes people, especially elderly, they're grazing throughout the day. They don't really have standard meals. They're not on a time schedule, and often they're told to take insulin with meals, but when they're snacking all day long, it can result in an A1C that's elevated. So sometimes just talking with a dietitian specifically about those details can really help. And the overall is the quality of life that he has. Does he feel energized, or is he kind of wiped out with the A1Cs and getting up at night and having to go to the bathroom a lot? So he might benefit from a decrease in A1C.
So he eats twice a day, the patient that I'm talking about, and he does have a snack sometimes in the middle of the day. He's on a routine where he eats somewhere between 7 and 10 a.m. every day, and he eats again at between 4 and 7 later in the day, and that's when he checks his sugars, and that's when he administers his insulin. And I've seen his setup in his home, and he's overseen by his daughter, who doesn't live with him, but she helps him set up his medications, and she manages his finances. And she and her brother buy his groceries for him, and so that's how he selects his food.
Thank you. I also kind of wonder about what they're drinking, and if they're a milk fan, drinking milk during the day. I mean, there's just little things like that that a dietitian can kind of pick up on that might help overall. And then of course there might be, changes needed in insulin dosing, and timing of insulin. Sometimes people are taking it well after the meal, but yeah, I'd kind of like you to be my doctor when I'm a little bit older. I think I'm going to have to move.
Thank you.
Chris Taylor, I think did you want to just offer your suggestions too?
Yeah, and I think there's probably a good reason why somebody has made it to 95 in terms of there's some longevity things happening here that I think their bodies just generally responded well to their eating over time. But I think being able to kind of maintain their strength and function will be important in terms of protein, kind of reduce the risk for falls and other things that might become the negative quality of life aspects. So the ability for like Meals on Wheels, or even if there's like a faith-based organization that's doing home deliveries, might help infuse some additional food into the household, take some of the burden off of his own self-care. That would also give some personal contact to help kind of maintain that quality of life, as it sounds like he's been kind of isolated in COVID. So a couple different resources that are out there that might help provide some more balanced meals and take some of the onus off of him in that aspect.
Thank you. So the bullet points I'll take home then is find a dietitian who does house calls, or maybe set up a virtual visit with a dietitian, and also look for other sources of food for him. Thank you very much. I could ask one question. Would I lower his risk for hypoglycemia if I were to switch out his sliding scale and maybe switch it over to keep the basal glargine and switch out to, say, glipizide or something like that in the afternoon or morning and afternoon? What do you think about that idea?
I would probably not use a sulfonylurea. Unfortunately, with his EGFR, it's going to just be too prolonged and sort of unpredictable.
Okay.
I was actually wondering if maybe even a DPP-4 inhibitor in combination with basal might be, a reasonable option. But whether or not he can afford that's another question on Medicare. That can be pretty challenging. Right.
Yeah, I think you're right. I'm not sure that he could afford something like that.
Mm-hmm.
So thank you very much for the comment.
Right. Okay, so with that, we are almost out of time. So I'm going to send the conch over to Jessie for our wrap up.
All right, thanks everyone. Just the usual reminders. You are able to watch the recordings of these sessions on our website. For this current series, you do need to make an account on cardio.org. And if anyone's having any issues activating their account, please feel free to email me and we can troubleshoot. You should have the post-clinic survey for this session in your inbox already. And then just a note, as we're kind of getting to the end of this series, I'll be sharing more information about claiming CME credits in the coming weeks. Next week is our topic, type 2 diabetes in a rural context. That'll be presented by Dr. Liz Beverly. So we will see you next Thursday, and thanks for joining.
Thanks, everyone. Bye.
Thank you.